It is a pleasure for me to be able to stand here and talk about the clinical trial because it's a major landmark for the whole community, but it's also quite a challenge for several reasons. One of them is that the protocol itself is about 70 pages, and if we wanted to go through that in detail, it would take us probably several hours. So I had to condense everything. The other challenge is that the protocol is not yet finalized to the very last detail, so I might not have all the answers, which you'll have the chance to ask after this talk on the roundtable. And also, not everything is set in stone yet. For example, the dose is something that we are still negotiating. We are in talks with several experts around the world of what would be the best dose for our patients, because we are here, navigating between Scylla and Charybdis. You don't want to give a too low dose just for the sake of safety, because in a rare disease situation, you want, even in a phase 1 trial, what this trial is, where safety is the majority, is the main concern and the main interest, the primary outcome. We still want to give a dose that will have potential to be effective, and effectiveness is just a secondary kind of observation here in this study. So we will see whether we'll be able to demonstrate that. I would also like to add here, Spiller has informed you about the unfortunate situation of the Oxford team stepping down from the project. They have been really intensely working on the protocol, and I'm very grateful to them for all the input. But we still have Michelle Ferrar from Australia, who is very experienced. She was working with Zolgensma in the spinal muscular atrophy field, and we will do our best to find experts with a lot of experience and knowledge. So there will be a medical steering committee that will do its job in the most appropriate way before we submit the trial to the legislators, and then once the trial is ongoing, the medical steering committee will be the one taking all the decisions. It's never going to be just one person. So if I can walk you through, just the title of the trial. GAIN is gene addition in neurodevelopmental diseases, CTNNB1. But if I walk you through the subtitle, I talked about phase 1 and 2. So phase 1 means that it is about safety. So the whole protocol is set to show that this particular trial is going to be safe for our patients, but also that it's tolerable. So there might be some side effects that we could encounter, but these side effects should not be so grave that the patients would not be able to take them. We will, as I said, look also for efficacy. We'll have a lot of scales and other measures that we'll try to employ to tease out the efficacy of this trial, so we would know that this trial is actually benefiting our patients. But as I said, it could happen that it would be negative in the sense of efficacy, and then later trials would be the ones that will be where we'll have to discuss whether there needs to be an increase in the dosage or some other modification where we could also see whether it's efficacious. So the second, part of, the second kind of red marked text is open label. This means that this is not a randomized trial. Usually in these big trials, you would have patients who get the medicine and then patients who do not get the medicine, and compare the two. So here we only have one arm of the study. So all patients will receive the AAV9 therapy. And what we will use as a background for, to see whether there's some efficacy in this, of this treatment in our patients, this is the natural history study data. That's why we're so grateful for you to participate in the natural history study, because that will be our background to which we will compare the treatment efficacy. This is something that's still under question. I wrote here, this is how the protocol is set up now, dose escalation. But because we thought that we would go with a slightly lower dose, still a dose that we deem effective, and if after treating 3 patients with a lower dose, we would see no worrisome signs, we would be able to escalate to a higher dose. We are limited in in the dosages, but we know from the animal studies that there were no safety issues this is a medical term, I mean like how you express the dose, but 1 × 10^15, it means how many vector genomes you would inject in the patients. That was the higher dose that we used in our animals, and we didn't see any worrisome signals. And but we would go about 50% of that dose in our trial. So we still discuss whether we should give 1 dose only to all patients, or we should go into dose escalation. This is how this was set in the protocol that we currently have. So here we had the dose escalation method, and first patient would get dosed, and then we would have like 2 or 3 months wait to see how the patient is, how is his well-being or her well-being. And then the medical team, so the Drug Safety Monitoring Board, which is another board that we'll establish, who will be unrelated to the medical steering committee, and they will review all the data from the first patients, check whether all safety check marks are there, and if they will confirm that we are good to go, then we would go to the next patient. And as you can see, the cohort 2, sorry, okay. So maybe here, yeah, so here in the cohort 2, and then we would go to a slightly higher dose, and then this would then continue, and we have then, the protocol is even more complex, but I didn't put everything in because I don't think it's so important at the moment, because it's still under development. So the next kind of description of what our trial is it contains intracerebral ventricular administration. Peter has yesterday nicely explained how this will be performed. There was a lot of discussions what would be the best way of treatment of our patients. We have asked experts from around the world, from various, experts in various rare diseases dealing with different approaches. And we deemed that this might be the best approach for our patients for several reasons. It depends on how, first of all, we have animal data that show the biodistribution in this particular approach is very good, meaning that it's not only the cortical surfaces of, child's brain that gets treated, but it's also the inner parts. And since some of our patients also have dystonia, for example, this might be a better approach because those regions would also get treated. So although, in a way, it's an invasive procedure, it is, as Peter explained, a procedure that neurosurgeons consider as not so complicated. There's obviously, potential, complications like a bleed or an epileptic seizure after that, but in many patients that we see, at the pediatric neurology ward, we do this kind of procedures on a regular basis for example, hydrocephalus. There are a few complications. Infections, of course, are also a possibility which you would really want to avoid, but it is a possible complication. And then it's a study on pediatric patients. We had animal data from animals that corresponded to about 6 years of age in human age. So the first part would first go, the patients that would be eligible for the first part would be patients of 6 to 12 years of age. But then if everything was safe, we would open that up, and then we will include even younger patients from 2 years on. And this is I'm talking only about the first clinical trial. Depending on how this first trial on safety goes, then of course we will negotiate many more things regarding how to open this up if we would deem that safe. So this is a first in human study. So it's a major leap of faith to go from mice to big animals and then to humans. And there's been numerous studies where these first steps deemed either the drug effective, but then when it came to humans it wasn't, or it was safe in the animals, but then when it was given to humans it turned out it was not as safe as in animals. So it is a leap of faith, that's for sure, and we are not trying to make these things smoother. It is the way, and this is something that we'll have to embark on together when deciding whom to treat and how to treat. But there's some safety measures that we've taken. Actually, we've taken all the safety measures that are required by law and even more. So, for example, the legislators did not require us to work on large animals, but we still did that experiment just to show that it's safe. And indeed, in the large animals, there were no safety signals that would be worrisome, which was quite comforting. And also, it gives us some insight on which dose to use. So, for example, we took like a lower dose and a higher dose, and the lower dose was as effective as the higher dose. So we know that even if we go a little bit lower on the dosages, we still might see an effect of treatment. This study is also going to be ethical committee approved. Without that, it's not, none of this could really happen. And as I said, there's going to be a medical steering board of experts with experience and expertise in the field who have done that before, who have been involved in developing a study and going through it in the most rigorous way. And then we'll have an independent drug safety monitoring board who will review all the data that we will generate through the study to make sure that every next patient is as safe as possible and that we are not missing something that we should be taking into account. Also, Slovenia is a small country, but we have some experience in gene replacement therapy. We've been able to treat patients with spinal muscular atrophy with gene replacement therapy. Those were intravenous injections, but in spinal muscular atrophy, there's also possible complications, even though the drug is registered. And we have experienced some, but we managed to tackle all the complications, so all our patients are safe and fine and doing very well. So regarding safety, there's also some other things that we can consider which may give us some comfort that what we will, the study that we're going to carry out is going to be safe. So, for example, a very important thing for us is that we're using AAV9 virus. This is the vector. This vector has been now tested in so many trials that we can deduct to some extent. Of course, there's never 100% certainty, but we are using a vector that has been used before in other trials, in other modes of delivery, and it's proven to be relatively safe. So there's still complications. The virus does not replicate itself, but once you inject it to the human body, there is an inflammation that happens, and this, the body responds to the virus that's injected, and it can, these inflammations can be to smaller extent, but sometimes it can be also in a major, response, but we can deal with that. We know how to do that. There's protocols, and in our protocol also includes that particular steps that will prevent the inflammation to kind of get out of control. Also, because we've chosen the intraventricular injection, the dosages can be lower than what was given in the IV patients, because if you deliver the drug intravenously, then you have to get much higher doses for the drug to get into the brain. Here you directly inject into the brain, so that also potentially would lower the risks of some side effects. As you have seen yesterday for the animal studies, the vector does get shed to the other regions of the body, so we still expect that there might be some complications, but the protocol itself, as you will see a little bit later, includes preventive measures for that. The thing that's also comforting is that from the animal studies, we have seen no signs of harm to the animals. So the primates that were given this medicine were healthy primates who have normal amounts of of beta-catenin, and they were given the medicine which increased the level of beta-catenin, but still there was no signs that these animals would be doing poorly in any respect. And the dose, as I said, will be carefully selected so that we will try to do our best to minimize the risk. So there are certain risks. As I said, there's a first-in-human study is always, as I said before, a leap of faith. For example, in the example of myotubular myopathy, which was a study on a rare disease, they have very good signals in animals, small and large. But when it came to the study in humans, it turned out that some of the patients would have hepatobiliary disease, and I think 2 patients died. And this was something that was impossible to predict from all the data that was generated on animal cells and so forth. So there is a certain risk. It's possible that our patients have, a certain complexity that we cannot see or, predict how it will respond to our virus, which will cause problems. But to some extent, some of these issues could be solvable. So we also don't have, all the answers to scientific questions, and probably there never will be, all the answers. So we are also not. We can do a lot of studies and trials, but it's always another question. So, for example, with the dosage, if you would want to really pinpoint the dose even further than what we have do, it would take you a couple of years more to precisely define which dose spreads well and which it doesn't, and how the animals are doing. But still, the last decision will be an educated guess from all the data that we have gathered before. Also, it's impossible to predict, the outcome in a particular patient. Even, in not so rare diseases, some patients respond to treatment favorably, some don't. So some things are in medicine still highly unpredictable, and the outcome is always somewhat vague. Also, as I said, the intracellular ventricular procedures carry some risks. So if I now summarize kind of the whole study, so there's going to be 2 medical boards, and there's going to be a call to patients and families to ask whether you would be interested in such a study. Spilas has already sent like a preliminary questionnaire just for a feel of what the number of potential families would be. But there's going to be an official call after that, and those families who would decide that they would be willing to participate would then be consented, and then the pre-screening would happen. We would go through the genetic mutations that our patients would have, and then see other parameters that will be of interest to the study. And if once we identify those patients who will be the most likely to be safe in the study, we will enroll those patients, and they will be invited for the screening period. In this particular period, we will, for example, do another genetic test just to confirm that the genetic variant that the patient has is really there. We will check exactly what kind of mutation that is, and then to see whether it fits our inclusion and exclusion criteria. And then we will do, for example, also the MRI, which is crucial for our neurosurgeons to navigate and to exclude other problems in the central nervous system. And then we'll do if everything is fine, we'll also, one thing I forgot to mention is we'll look for the AAV9 antibodies, because in this particular trial we decided to really play super safe. So those patients who already have met the virus in its natural form and have produced the antibodies, we will exclude them because we would never know whether, if we would see no effect, then we wouldn't know whether this is due to the antibodies or it's because the medicine doesn't work. So if everything is fine, we will do the baseline testing. That would be quite intensive, because we would like to measure everything possible in our patient before we would start treating them, and then the dosing would happen. After the dosing, we would take a lot of care. I mean, this is of utmost importance. We would have to prevent infections, so we would keep the baby or the child in a hospital for a week in a very sterile, setting. So we would like walking gowns to the parents, and the parents wouldn't be able really to walk back out of the room. That's how we do it for the Zolgensma patients. And after 1 week, we would carefully monitor the patient. The first weeks are the most crucial. And if everything's fine, then we would, loosen up, and then the patient would be able to go, to the place where they would live for the time of the trial. And we would ask the parents to stay at least 4 months in Ljubljana, because so that they are very close, like less than an hour from the hospital, so we can help them. They will of course have all our contacts, but if anything goes wrong, then they would be able to come to the hospital where they would get all the help needed. And of course it doesn't stop when after these 4 months we would carefully monitor the patients after 6, 12, 24, 36 months, and that's the predefined end of the study. But we still, I mean, all the patients will be carefully followed even further than that, but this is not part of this particular protocol. So the question of how many patients is more or less, I think, set. I think it's about 12 patients, because that's the amount of doses that we are able to produce. As you know, production, we've heard yesterday, is 50% of the costs go to the production, and 40% of the product goes for the quality controls. So we are left with 60% of what Vidalhin has produced, and that corresponds to approximately 12 patients. If those patients would be very light, then potentially we would have, you know, another dose, but this is uncertain. So this study would be carried out at the University Medical Center in Ljubljana. We would take international patients. This is something that we have already, I mean, there are heavy negotiations with our hospital, and you know, there's a lot of logistics around this, but this is a solvable problem, and it's mostly solved. And there's going to be a team of skilled physicians that will be dedicated for the study. So we'll have cardiologists, nephrologists, and so forth, who will be all involved in this particular study. So they will all be, you know, alert when the study will take place and when we'll have a new patient, so that they could help if something goes wrong. To make it a little bit more visual, the patients would come approximately 56 to 14 days before the dosing, where we would screen the patient, we would repeat the genetic testing. Then about 9 to 7 days to the treatment, we would, sorry, there's a mistake. So from 9 to 1 day, we would have the baseline testing, and then the treatment period where the patient would be hospitalized for 8 days. And we would start some treatment with steroids for protection of the patients, and then dose the patients, and then carefully monitor them. And then from 7th day on, if everything goes fine, to 4 months, the patients would need to be in Slovenia, but then the rest of the follow-up could be remotely. I mean, we'll try to be as flexible as possible for patients to travel as little as possible. But for this particular follow-ups visits, we deem that the patients would need to come to Slovenia to be examined if, other arrangements wouldn't be made. So I was very reluctant to go through all the inclusion and exclusion criteria, because there's a lot. And but then since yesterday there were so many questions, I will still walk you very briefly through all of those. There's about 6 or 7 slides of this. So, but some of them are very straightforward. Some of them are maybe not so straightforward. But I want to walk you through, and then in the round table, we can go into more details. So the study will include male and female patients aged from 2 to 12 years. If there's 2 parts, we'll have the 6 to 12 and then 2 to 12 years. And the patients would need to have a confirmed diagnosis of CTNNB1 syndrome. The parents would need to sign the informed consent, and they will have to comply with the protocol visits and procedures. They will need to reside for the first 4 months within 1 hour of the site. They would need to be, the use of concomitant medications would have to be stable for at least 28 days prior to the initiation of study. They would not be allowed to participate in any other interventional study. In female participants, will have to make sure that the urine pregnancy test is negative, and they would. This is also important. It was mentioned yesterday that all children that would be treated this way would have to refrain from future donation of blood, blood products, tissue, organs, and so forth. These are the inclusion criteria. Now I'm going to go through exclusion criteria. And there are several topics of those. So for example, genetic, this is something that this particular bullet point we added because of our genotype-phenotype study. There are some variants that could potentially be more problematic, and we will try not to include those patients in this, this first trial. We were testing those variants. They might not be problematic in the sense of AAV9 testing, but this is something that can open up in the next trials if they're going to happen. But for now, we were trying to be stricter to be safer. Also, if there's a concomitant genetic diagnosis or a neurodevelopmental syndrome, then a patient would not be eligible. We will test each patient for the AAV9 antibodies. So any patient that would have a titer higher than 1 in 50 for the AAV9 neutralizing antibodies would be not eligible for this trial. And also, if the patient would be hypersensitive to any of the ingredients of the medicine, that it's very unlikely, but still it's stated there we'll have to test for that. If the patient wouldn't be eligible. Also, if the participant were receiving immune modulating agents within 3 months prior to the dosing, the patient would not be eligible. Then regarding the infections, a significant concurrent illness or infection within 30 days prior to dosing, which would compromise safety of the patient, would be excluded. Patients who would have HIV or hepatitis B or C infections would also be excluded. And then there are some neurological exclusion criteria. So if there's a concomitant neurodevelopmental disorder, so like if the patient would have 2 disorders, it's very rare, but it is possible. We've seen that before, that those patients would not be eligible. And if a participant would have a congenital malformation that would affect the nervous system, so sometimes the baby's brain is really malformed, such a patient, for example, would not be eligible as well. Also, severe traumatic, metabolic, vascular, or infective brain injury would be preventing the patient to enter the study. Also, if the patient has contraindications to go into MRI, so if they would have some implants that were incompatible with the MRI, that's also a problem. Also, we will look, although many of our patients don't have any seizures, so like, for example, those patients who were examined last year in Ljubljana, then did the EEG, none of them had epileptiform discharges, so it's very unlikely, but it does occur. Some patients do take medicines for epilepsy, and if there would be a significant increase in seizure frequency before initiation of trial, we would also be reluctant to include that patient. Participants with severe contractures where they would not be able to complete assessments that we have proposed, that would also exclude the patients. Of course, many of our patients have contractures to some extent, and this is fine, but only if it's like extremely severe, that would be an exclusion criteria. Also, if the patient would have increased intracranial pressure, a central nervous system tumor, a vascular abnormality, or any other major structural abnormality would be excluded. And there's cardiorespiratory exclusion criteria. So, for example, a participant who would have a very significant congenital cardiac defect, and the medical team would deem that this could pose a problem for the patient, would be excluded. And if the ejection fraction of the heart, so if the heart is really functioning on a very low level, that would also make the patient more at risk, so it would not be included in this safety trial. Also, participants with a clinically significant cardiovascular abnormality would be, abnormalities of the rhythm, lung QTC, for example. Those things would be also giving patients at a higher risk. Also, if the patient is unable to tolerate anesthesia, that is something that is needed for the procedure, that would exclude the patients. Also, patients on invasive ventilatory support within 6 months before enrollment would be excluded. And a pneumonia requiring hospitalization the previous 6 months is also an exclusion criteria. So I know it's a very long list, but and many of those would, that don't even apply to most of our patients, but this is really there for the safety of anyone that will, this is everything that we're going to look and more than this actually. So so in the hepatorenal sense, we will look for it as at the liver enzymes, because we expect potentially, we know that AAV9 virus can increase the liver enzymes to some extent, and those patients who would initially already have higher levels, those would be excluded. And also the renal function would be tested. And there's some general exclusion criteria. So if the patient would have very significant thrombocytopenia, neutropenia, anemia, that wouldn't be that wouldn't be just transient. That would be also something that we will consider to be a risk factor and not include the patient. And also, if a patient would have a biopsy-confirmed malignancy, that's an exclusion criteria. A major surgery within 6 months prior to enrollment, a significant concomitant medical disorder, or if the patient was enrolled in another interventional clinical trial within 1 year prior, or if the patient has previously received gene or cell therapy. So we're through. But it's a very long list, but we have worked very hard on selecting these criteria because we still think that there's going to be a lot of children who will be eligible for the study, but we really want to focus now on the safety part, because if we get this wrong, the whole project can be stalled and could be could end really. So we have to play it safe, but still we do want to do it in a way where we would like to see some efficacy. So this is just part of the protocol, just to see how extensive the examinations are going to be. You see here the screening period, the baseline period, the treatment period in blue, where the patient is hospitalized, and then the core observation period to the 4 months after the treatment. And we will do various examinations in this time to make sure that the patient is safe. Besides Urbagin, the patients will also receive 3 other medicines. The first is methylprednisolone, which is a steroid which the patient will get intravenously at the time of dosing. And then the prednisolone, which is also a steroid, which the patient will start 1 week prior to treatment, and then for 10 months, for 17 weeks after that. So this is the steroid treatment is something that we also give, for example, in SMA patients who receive Zolgensma, because we know that AAV9 virus has a potential to go into the liver, and then it causes acute liver failure. But it's a treatable, it's a predictable side effect. We know that it can happen, and we can really calm the inflammation with the steroids, and it's after a certain time this goes away. What the good thing about our product is that it has some regions in the cassette which will deactivate the expression of the transgene in liver and in dorsal root ganglia, which will make this drug even safer, because we don't expect this major increase. But 17 weeks of steroids is there for the sake of safety, and we think this is nothing that would cause long-term steroid treatment problems for our patients. That we see in patients who have to take them for years. So we've done it in patients with SMA. They usually didn't have any problems with that. We will also give sirolimus for 10 months, which is another immunosuppressant. It has a slightly different mode of action, but it has more effect on the T cells. Because when we introduce the transgene, there's going to be the more protein in the body, and there's the viral component to the treatment, and this kind of calms down the immune system to the extent that it doesn't happen that the patient would have a very severe inflammation. So with that, there's going to be, as I said, 4 months follow-up, and then the sequential follow-ups afterwards. And what is really important actually is, and this is my last line, is that this is a team effort, not just on the medical and scientific part, but also with the families. So we will really make sure that the families who will be enrolled in the study will be very tightly connected to us. We will have to be working as a team, a very good team, and where everything is transparent, everything is said up front, everything is straightforward. All the questions asked, all the answers given, at least if we can give them. And we really think that this particular part of collaboration is extremely important for a study like this, because that provides a very good opportunity for the patients. And if there's any kind of doubts and the patients stop visiting our follow-up visits, that can pose a problem for patients. And it has happened around the world that the patient would get very sophisticated medicines then in a major city, and then they would travel to a local hospital, never came back, and the patient had a very poor outcome. So with that, I would like to go to the last slide, and which is it's very speculative. I might get things wrong here, but just to to see how we think about this medicine, and because it's very important that you understand it as well. So first of all, I mentioned it yesterday. This is not a cure. So the genetic variant that your child has will stay there. So it's not going away. This is, as of yet, with this particular treatment, it's not possible to remove that. But it is a therapy. So, because of the variant that the child has, there's less beta-catenin produced, but with the therapy, we will increase the levels of beta-catenin in many cells, not probably in all, but in many cells. So we do think that it's possible to improve this. But you have to be aware that we have to set realistic expectations before entering the trial. So it's very unrealistic if the child is severely spastic, if the child is very dystonic. We've seen yesterday the amazing story of Irai, and it's really incredible. It's how this little girl has improved after the treatment, but still, even after the treatment, which is so successful, where you can see it with the naked eye, even if you're not an expert, this little girl was not completely healthy, and this is, I think, very important for you to understand as well. And also, I think we have to know that we don't know the magnitude of the improvement that the child is going to get. So it's possible, that this medicine doesn't really work, because this is going to be the first in human trial where we're going to see if this is happening. So it's possible it doesn't work, but it's also possible that it will work to some extent. And this is important to understand, that the spectrum of outcomes can be quite large. So, but there are some things that are more optimistic maybe than this first kind of part that I've told you. So in the phenotype study, for example, a third of parents reported that there was some regression on the progression of symptoms. And I think that with normalizing the levels of beta-catenin, the body of the child is going to function more normally, and maybe this will help slow down the progression in patients who would progress otherwise, or maybe prevent the worsening of the symptoms. And also, some parents reported on progressive spasticity. So maybe, with treatment, this progression will not happen to the extent that it would happen otherwise. Also, I mean, since the new levels of beta-catenin, this could, decrease the symptoms of the disease. So we've seen that before for example, in SMA patients, in very symptomatic patients. They will be treated, and the symptoms that they had, for example, extreme hypotonia, lack of development, those did improve. So there is hope that this would also we would also see this in our patients. And maybe with the medicine, some patients were not achieving milestones as planned, but with the medicine, where normal development will be able to build on a more kind of normal biochemistry, new milestones will be achievable for our children. And we certainly hope that there's going to be improvement in quality of life. It's really impossible to predict how, in which sense our patients are going to benefit from the medicine, but it could be that, generally speaking, the quality of life would be better, for the patients, for the families. Maybe there will be less behavioral issues things like that. So, but this is all speculation. So, and what we can't really expect is to be, and this is again, I'm on the other side of the spectrum. We will not see completely healthy children, I think, and we will not see the disappearance of all symptoms. So maybe I ended up on a more pessimistic tone, but I think it's much better to be very, very careful and very down to ground, and then see, improvements that will be, that will make us all happy. And if our children are going to go through this clinical trial in a safe manner, if everyone is going to be fine, we'll be happy with that, only that. But if we'll see some improvement, that's going to give us even more hope. And that would also be the basis for the next trials. I'm very happy about the previous lecture where you've seen that there's other steps that are coming about after this first clinical trial where you go for efficacy, and then if things are going well, then you can go to a major clinical trial where you have when you get a really statistically important data on the improvements you see in patients, and that we hope is the way our treatment is going. So with that, I would like to thank you, and we'll have a round table, and we'll have time for discussion.
Wow. Lots of information, but I think it was so important to get all these details. And thank you so much, Damjan, for giving. We all appreciate the hard work your team has put in creating the protocol, because it's a big, big thing for all of us. So I'm really happy.